That was one of the first LPs that we actually owned. For those of you who remember.
When you shoot selfie, this thing's selfie. Selfies, I thought it was selfie.
With a stick.
We have the pleasure tonight of having Dr. Etz Chaim here to talk about dementia and Alzheimer's disease, something unfortunately that each of us has run into with relatives and friends and will continue to run into as people continue to live longer and longer. A lot of research is being done in this. Bernie just told me that the Wall Street Journal had an article today,
2 weeks ago.
2 weeks ago, about all the money that's being spent in research for this horrible condition. Without further ado, Dr. Chaim. Oh,
Thank you.
any questions, please write them on the pads, hand it to me, and I'll ask them later.
Or I keep it pretty open. I think the last time I was here, I don't remember what I talked about last time. Back pain? Oh yes, how long ago was that? Was that 2 years ago? Wow, all right. I thought the weather was warmer.
It was actually in the spring.
I think it was actually in the spring, yeah, like in the spring of 2014, about 2 years. Thank you for having me again. It's always a pleasure to come here. And thanks for coming out for the cold night. This is a talk on Alzheimer's. A lot of this might be a lot of medically oriented. If you can follow along, great. If not, just, you can ask questions about it later. So, all right, so we all know who that is. Right, Ronald Reagan, nice guy, very, very nice guy, even for people who may not like him politically, but some like him. I don't doubt that he was a very nice guy, and that's what I always say about him, because and then when did he pass away? I think 2004, 2004. He was in his 90s. He had Alzheimer's for a good amount of time. Remember, the reason why I bring up this slide is that Alzheimer's is not you suddenly don't wake up with it. It had been developing for years and years. Whether he had it when he was president, it was quite a long time, but we'll never know. Because he was 69 when he got elected, and then he finished in 88 when he was 77, and he wasn't diagnosed for a good amount of time thereafterward. Not for a while. So, all right, this is what I used. I wanted to put together I guess, can we focus a little bit, or is that me, or is that my eye, or my eyes? Because I just had a cataract.
It is cover the sound a little bit.
A little better.
Okay, all right. A couple things that I want to let me see. I think I get this. Okay, so there's two definitions that I always use. One is a neurologic definition done by the National Institute of Health, and then the psychiatric definition, okay? And one thing that I wanted to stress, okay, because I hear a lot of patients who say this, or families who say this, is that, my mom or my grandmother or whomever was diagnosed with dementia. What I always say is dementia is a symptom, right? So dementia as a symptom, does this have a pointer? I think it does, yeah. Yes, so dementia as a symptom, as defined by the neurology, deficits in 2 or more areas of cognition, and this is the main word you want to remember. Progressive worsening of memory and other cognitive functions, no disturbance in consciousness, meaning that if I hit you over the head and you're unconscious, you're not going to be able to answer the questions, and certainly you're not going to be able to tell me what the date is or where you are. So you're wide awake, and you have progressive worsening of memory or other cognitive functions. You don't have a brain tumor, you don't have a stroke or anything. And it's usually between 40 and 90, and it's most often in our senior, elderly, older population, and 2 or more areas of cognition. Dementia is always a symptom. So we always go to this. This should say DSM-5, but it's largely the same. The DSM-5 just came out, I think, a year or 2 ago. But cognitive dysfunction in both the following: memory impairment and 1 or more disturbances in cognition. So memory impairment is one of the hallmark features of dementia. And we all know, we all kind of have slower memories. I'm actually having trouble remembering people's names these days. I was never really good at it, but that isn't necessarily any reflection of cognition, as a whole, because hopefully I can still perform my job okay. But a lot of this is very, very parallel to the previous report. Impairment in functioning, decline in mental status is progressive, not due to medical, neurologic, or toxic cause. Neurologic, meaning like you had a stroke, you have MS, Any of those can cause cognitive impairment, but wouldn't be considered dementia. No delirium, no psychiatric disorder. So the thing that I want people to remember is that dementia is a symptom. When people ask me about dementia, they say, my grandmother has dementia, and I says, okay, well, what kind? And then they'll say, well, dementia. And you all know Alzheimer's, right? So when someone mentions dementia, a diagnosis that I say is, well, that's not a diagnosis, it's a symptom. The diagnosis would be dementia as a result of Alzheimer's, so like dementia of the Alzheimer's type. If you had lots of strokes and they built up or not enough blood was getting to your head, you would have dementia of the vascular type or dementia secondary to multiple strokes. Then there's something called Parkinson's disease dementia, all right? Or dementia of the frontal temporal type, and the list goes on and on, but for the most part, about 50 to 60% of the cases are going to be dementia of the Alzheimer's type. And certainly you can have a mixed condition, but that constitutes the majority of them. What I see a lot in the hospital is that people automatically equate dementia with Alzheimer's. And they are the same, but remember, Alzheimer's is a subgroup, is a more specific subgroup of dementia. All right, so dementia inhibit. That's Linus Pauling. He's a very smart guy. Apparently he was doing very high-level research up until the day he dropped dead at age 93. Dementia is not and should not be considered part of normal aging. This is, I guess, just a word of optimism, and that someday we can maybe slow it down, do something about it. Okay, so the prevalence of dementia, 1 to 3% of those above the age of 65. It doubles every 5 years, and over 85, it's about 30 to 40%. Okay, I always tell people, I have my own father-in-law was 88. He passed away from other reasons. He had B-cell lymphoma, but he was 88, and I think even when he was in the ICU about to pass away, he was still very, very sharp. I mean, we saw him when he was well into his 80s, and he was hard of hearing. He had a broken hip. He had a lot of trouble walking, but he was still asking me about. He wasn't asking me about his daughter, who I married. He was asking me about articles that he had read in the New Yorker. Just a week ago at a very, very high level. So he was clearly not demented. And my stepmother-in-law had actually expressed anxiety to my wife prior to going to visit him that time. And she's kind of alarmed this. She's very, very anxious. She's got a lot of medical problems also. And she kept telling my wife, I think your father's losing his memory, blah, 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 blah. And my wife just says, okay, well, we'll be visiting in a couple of weeks. Let's see. So I sat down, and the first thing he asked is, Ed, did you see that article about written in the New Yorker about healthcare, and comparing it to this Texas town and in Rochester, Minnesota, with the Mayo Clinic? This was an article from about 2010, I think. And then I proceeded to have a 5-minute discussion with him, and then when we stepped out and in another room with my wife, I just told my wife, Rachel, just FYI, there's nothing wrong with your father's memory. Okay, so there are risk factors for it. These are things that may or may not be. There's all these genetic factors, presenilin 1, 2, ApoE. These are genetic risk factors that predispose you to forming the abnormal proteins. I think you guys might, yeah?
What is APOE, please?
It's apoprotein.
Protein?
It's a protein, yep.
What's blah blah?
Blah, blah just means that there's all these genetic factors that I didn't feel like getting into, because I could go on and on about it. And these still, some of them are risk factors. This is a risk factor, okay? This is actually, the ApoE is probably prevalent in about 20 to 30% of the population. It puts you at risk for it. This is present in a very, very small percentage of people, and that is actually kind of like a cause of it. So when you have this, okay, and please don't, I don't even think a test is commercially available, so please don't go out and ask your doctor, can I get tested for it? This actually causes it, but it's a very small percentage of the population. This, we all have it. Either apo, lipoprotein 2, 3, 4, and they found out that people with 4 have a slightly higher risk of developing it. But remember, it's a risk factor, it's not a cause. When we look at aluminum, this is something that was in vogue about 20 years ago, so I knew people who asked about aluminum and what's in deodorant? Aluminum hydroxide. So a lot of people, they stopped using aluminum hydroxide deodorant because they thought that then it might risk.
A lot of food products too, I think.
A lot of food, and then some people said don't drink soda from aluminum cans. This was never shown to be proven. B12, folate, thyroid, those are all what we call treatable causes of dementia.
Why are the B vitamins problematic?
Hey, not having enough of them.
Lack
A lack of, yeah. So basically, these serve as cofactors. They're basically substrates. They serve as cofactors for metabolism and formation of protein and other essential protein and factors. And if you don't have them, actually, I don't exactly know the exact mechanism behind why lack of B12 or folate causes dementia. Normal pressure hydrocephalus. That means that there's too much fluid in your head, and it gradually builds up, and it's called normal pressure because your brain kind of accommodates the increased fluid. The pressure doesn't build up, but it kind of stretches out your brain.
Is that what football players get?
What's that?
Is that what football?
That is chronic traumatic encephalopathy, and that is something different. That's just some protein forms abnormally from the repeated, shaking of the head, hitting of the head, the torsion injury over and over again, and that's actually now being studied. That would be considered a form of dementia, and a lot of the abnormal protein that is found on pathology in that is very similar to that of Alzheimer's disease, but not exactly.
Is
Yes.
there something about the definition of Alzheimer's excluded neurological reasons for?
Well, meaning like I guess Alzheimer's people. There's a lot of crossover, so people can certainly have concurrent conditions, all right? But to diagnose exclusively Alzheimer's disease, you can't really have, strokes, you can't really have a B12 deficiency, you can't have a lot of that.
But you can diagnose dementia.
Yes, you can diagnose dementia, yes. Other things that put you at risk: high blood pressure, diabetes, cardiac disease, strokes, white matter ischemia. I just say that when you're not healthy, your brain isn't healthy. Whether it's the blood, the blood to your brain, the pressure gets too high, or the glucose levels get too high. No one knows the exact mechanism behind it, but healthy mind, healthy body. Your body's not healthy, it's going to do some damage to the brain, either directly, acutely in the form of strokes, or indirectly in the terms of like chronic hardening of the arteries to the brain. High diabetes, strokes from the heart, strokes from like narrowing of the blood vessels. But like I said before, these wouldn't necessarily cause Alzheimer's disease, right? They would cause like a vascular dementia or a stroke dementia. Okay, differential dementia. So, anyone remember who that is? Rita Hayworth. Yeah, she had Alzheimer's also. Okay.
Not when that picture was taken.
I don't know. I'm in the 40s. All right, so when we differentiate dementias, we look at the underlying cause, if there is any. But remember, a lot of them have no clear cause. It's not like I have a blood test. It's not like I can do an MRI and something will definitively say it's Alzheimer's. There's Alzheimer's or frontal dementia. The way we differentiate them is we look at the spacing of the symptoms. Right, the temporal spacing, okay? I always joke that, look, ultimately everyone winds up in the same place, right? We all die, all right? And everything winds up in the same place. But before that happens, certain things might happen earlier than others. And that's actually important. Even if I don't have a cure, okay, we know what to look for. We know in certain types of dementias, we actually have to focus on certain things with the caregivers. And on other types of dementia, we have to focus on other things, and I will get to that. So the neuropathology, I can quickly go through this. There's abnormal. I actually found this fascinating. When I mentioned that in Alzheimer's disease, there's basically abnormal plaques, neurofibrillary tangles, Hirano bodies, neuritic plaques. One of the recent therapies or preventive therapies for Alzheimer's. I don't know if anyone's heard of it. It's an Alzheimer's vaccine. Anyone hear of that one? It hasn't been shown. It hasn't been shown to be successful. Okay, sorry.
Can it hurt?
Huh?
Can it?
I don't know if it had any bad side effects. It was a very exciting thing to look at, and
Only a
just
few people died.
it wasn't shown to be effective. And I'll tell you what. And then this is what even if it's more medical. Activated microglia asteroid beta amyloid precursor protein. So they discovered that the difference between an Alzheimer's brain and a normal non-Alzheimer's brain was the presence of protein or abnormal protein. And the abnormal protein was abnormal and potentially toxic because the brain protein would come in sheets, okay? And then they would fold over. And if you guys remember in your old high school chemistry classes, there were like molecular bonds, and the sheets would fold over in an abnormal way. And then they would fold over, and you couldn't unfold them because the bonds from the top sheet and the bottom sheet, when it doubled over on itself, it would bond to it, and it would get stuck like that. All right? You ever take a rope and you spin it together, and you go like this? What does it do? It winds together, right? Now imagine if the bonds from that bonded together. I don't remember, like, there's a sulfide bond or a methyl bond or something, okay? So there's an enzyme that cleaves those groups off, and that vaccine was supposed to cause the body to form an antibody to the enzyme to prevent the enzyme from cleaving the tail, the group, like the methyl group or the sulfide group, so it didn't fold over. It actually didn't work very well. But these are all like the different proteins you can see. This is how they definitively identify Alzheimer's disease on neuropathology. So when the person is alive, there's obviously things that are very, very characteristic of Alzheimer's disease, all right, like memory loss, visual spatial problems, okay? It should not affect your language, at least not initially, and it should not affect your motor function, at least not initially. But definitive, like gold standard, is we look at the brain under a microscope, okay? So, I don't know, you guys remember this? The Brady Bunch, I just threw that in because Brady, Brady meaning slow. All right, so there's a broad range of symptoms in any type of dementia, including Alzheimer's, which would be cognitive, which we discussed already. Memory problems, visual, spatial stuff. Very interesting. Way back, artist named William de Kooning. He had Alzheimer's disease. An artist. He probably has good visual, spatial ability. He was an artist, but a lot of the people studied, his visual, spatial representations in his early art when he was not suffering from Alzheimer's till later. And they actually like to compare that and see how everything changed. Affective, Alzheimer's disease, Parkinson's dementia, all these associated with depression, mania, impulsiveness, all depending on which part of the brain gets affected first. Psychosis. Psychosis refers to like hallucinations, delusions. Parkinson's disease, dementia, they tend to have hallucinations, visual hallucinations. They will see things. I just had a patient today. I see relatives of mine who had passed away. I see strangers coming in asking for money. I see animals. I see ghosts. I see little children. They're very, very vivid about this, the Parkinson's disease, dementia. Alzheimer's people tend not to have visual hallucinations. Their psychosis tends to be delusions, paranoid delusions sometimes. Like, I don't know, hopefully, if anyone has any family member, typical case, this is almost like cliched, it happens so much. They place things, they misplace things, they lose them. What do they think is happening? Someone's stealing from it. You can't convince them otherwise. I had a patient who thought that their maid had stolen their checkbook, and then I said, well, or their cleaner, not their maid, their cleaner. And I says, well, do you still see her? He goes, well, yeah, she's still around. She still cleans, apartments for other people in my neighborhood. And I'm like, that's it's possible that a cleaner could be stealing from you, but then I started to get suspicious because usually cleaners, if they wind up stealing from someone, it's going to get around and they're not going to have a job anymore. So for the most part, most of these people are very, very cautious. And I said, so what happened? Did you call the police? And she goes, well, I went to the police, but they said without any hard evidence, I can't, arrest anyone. I said, okay, well, what did you do? He goes, well, a week later I actually found, did you close your account? I said, was any money taken out of your account? He says, no, because I checked the bank. Well, did you close your account? He goes, no, I went back to close my account, and then I found the checkbook again. And I says, well, I thought you said your maid stole it. Goes, and then, you know what he said? The cleaner had taken it, and she put it back.
She put it back.
Yeah. And so at that point, I'm like, all right, this guy's not... And they are very, very confident in what they're saying, because they really believe this is going on. So he actually once brought a friend of his who was not demented to my office, and we sat down, and I looked, and I was hoping that, you know, she would help some, you know, maybe try to get him some treatment, get him some help, most importantly. And I says, well, how's he doing? And she said, well, he's doing okay, but, you know, he's kind of stressed because his cleaner was stealing from him. And I went, oh my God. And then he told me, I love this story, he goes, and then he told me that his landlord had bugged his telephone. And then I says, well, why would they bug your telephone? He goes, well, they're trying to get me out of the apartment. Okay, that's possible. There's landlords here, you know, if they want to get their tenants out of rent-controlled apartments so that they can go market price on it, you know, that's possible. So I'm trying to give them the benefit of the doubt. And he goes, well, how's he doing this? And then he goes, well, you know, my cleaner's collaborating with him. And at that point, I kind of realized that it wasn't. So with the Brady's, things slow down. All right, so meaning slow. So bradykinesia meaning slow movement, like in Parkinson's disease. Bradiphrenia, you know, you start thinking slow. Your processing is slow. You don't answer questions as quickly. You don't respond as quickly. People with dementia often, even if they're of good strength, they're of regular vision, a lot of times it's not safe for them to be driving because, you know, you got to respond very quickly when a car comes or someone's crossing the street. All right. So there's numerous, you know, we all remember him.
Moses.
He played Moses and
President of the NRA.
Taylor,
President of the NRA.
the president of the NRA, and was it Taylor in Planet of the Apes?
Yeah.
Taylor, right, and Ben-Hur. Charlton Heston, yeah, he had Alzheimer's also. And then just because there's a wide variety of symptoms involved in dementia, there's a wide variety of neurochemical pathways. Acetylcholine, people have all taken, this is supposed to be, NMDA is supposed to be toxic or excitatory. So I'm sure a lot of the people here, they have family on different medications. So a lot of the medications that we prescribe for Alzheimer's increase acetylcholine. It slows the breakdown of acetylcholine because that's kind of like the chemical that is found in the brain, you know, for thinking. You guys, everyone has heard of like Aricept, Exelon. Those all increase this medication, okay? A medication called Namenda, some people might be on it also. Remember I said this was, when you activate this too much, it becomes toxic. So Namenda is an NMDA blocker. And you can see how they came up with the name. You know, just, you know, put an A there, put an EN there, and you get Namenda. Serotonin and dopamine are linked to when you get too much of it, you can become psychotic. When you get too little of it, you become depressed. So we increase these levels with antidepressant medications, because I had mentioned before, a lot of people with Alzheimer's, dementia, and other dementias, they'll have depression. Okay, so acetylcholine, you know, if it's low, cognitive dysfunction, okay. Anticholinergic, and it's odd because one of the things I find fascinating about the whole subject is that when the acetylcholine is low, you have cognitive dysfunction, okay? But sometimes when it's low, you get psychotic. But other times, when it's high, you can get psychotic also. So a lot of the dementias, it's not just a matter of one is low, one is high. We always think about it as a dynamic process. So it's not just a matter of having too much chemical or not enough chemical. If you have too much chemical and not enough brain cells, you get psychotic. If you have not enough brain cells and not enough chemicals, you could not be able to move. So sometimes you have a paradoxical effect depending on, whether the medication is high or low. So this is how, this is the Nepazil, this is how the Aricept works. These are some other ones. The Nepazil acts almost all just on the acetylcholine. Some of the other medications, just when I listed all those symptoms, these will act in other neurochemicals also. And the interesting thing is that if there's lots of neurochemicals involved, you might expect that the ones that involve more neurochemicals are what? More effective? They're actually not. They're all about the same. Remember him? He's actually one of my favorite. Does anyone know who that is?
Captain Kangaroo.
Captain
Bernie
Kangaroo.
Sanders.
Bernie Sanders. Who is?
Buckminster Fuller.
No, he looks familiar. I don't know.
It's Aaron Copland.
Oh, yeah.
Aaron Copland. Right? That's one of my favorite composers. I think he's from Brooklyn, I believe.
Old guy.
Yeah, he died in 1990. He had Alzheimer's. I actually had a patient who actually met him in his 90s, and he was. I was like, well, what was he like? He was demented. He was demented beyond belief at age 90. But he made it that way. He made it that far. So this is the Nepazil Aricept. It's simple. Just I'll preface by saying that I'm not. These medications all theoretically are supposed to work, but they're not really that impressive. So, if you want them, I give them to you. What they're shown to do, they haven't been shown to dramatically improve cognition, and then they haven't been shown to slow the progression of the dementia. What they have been shown to do is to delay nursing home placement. So what happens is that if you get the medication, in 2 years you're going to be at the same place, okay, whether you had it or not. But if you get the medication, you might be able to hold on at a higher level for about 6 to 12 months before. And then, maybe at 18 months, you have a sharper decline so that at 2 years you're at about the same place. And this has been out since 1998. I offer it to everyone, but I don't twist anyone's arm to take it. And I have lots of patients who think that it's working. Well, if it's working, I keep it. But I have a lot of patients that where it's not working, it's causing a lot of side effects.
Such as what?
Blurry vision, diarrhea, upset stomach. Because the same neurochemical that it's increasing, the acetylcholine, also causes your mouth to water, your GI tract to move faster, diarrhea, flushing, sweating, okay? They're having these bad side effects, and then their families are saying, well, this is the only medication for Alzheimer's disease. And I said, well, you know what? It's not even worth any side effect. Your comfort and your general state, feeling of well-being is much more important than any alleged improvement on it.
Are we gonna? I have a question.
Yeah.
Are we gonna talk about how to avoid it?
Yes, I think I'm pretty sure I have a slide later. I can go through these quickly. This is another medication. This was designed more for the medical residents, but see, this works at different neurochemicals. All right, there's fewer side effects, they say, but in my experience, they're all about the same. Okay, this one promotes dopamine release, so they say it might be useful when you have Lewy body, you have Parkinson's disease dementia, or you have Alzheimer's dementia and Parkinson's disease dementia.
What is Lewy body?
I'm sorry. Lewy body dementia is effectively the same as Parkinson's disease dementia, because the Lewy body is the abnormal protein in the Parkinson's disease. The neurofibrillary tangle or the tau protein is the abnormal protein in Alzheimer's disease. And there's a lot of overlap, with other dementias as well. Yeah.
To go back for a moment to the Aricept.
Yes.
You said that there was not that terribly much difference, it's just that it delayed it for 6
Yes,
months.
yes.
Is there research that indicates how early on you start the Aricept?
It's indicated for mild to moderate cases. So when you're very, very severe, it's not shown to do anything.
Okay, so you're saying
Yeah.
that if a person begins to not be good at time and say things like, you never told me that, or I don't remember that, or whatever, is that possibly the time to start Aricept?
Yes, I mean, It's very innocuous in the sense that, it's not, it doesn't have, it has minimal drug interactions. People have side effects to it, but for the most part, it's very, very well tolerated. So I just started. So I'm sure I started it on people who don't even have Alzheimer's disease. Okay, they may have had some memory, or I'm talking to them, they absolutely positively insist that, there's something wrong with my memory. They may or may not have it. Our memories all slow down when we get a little older. All right? It doesn't mean we're demented.
But do you base it partially on family history?
Yeah. I mean, that'll contribute to it. I mean, they'll say, oh, well, my father had Alzheimer's.
Starting Aricept earlier, would you base that on family history?
No. I mean, I'm so loose about it just because I'm so unimpressed with the results of it. If you want it, I have no, I'll go through the whole explanation as to, this is what it will do, this is what it won't do. And the most important thing that a lot of doctors fail to take into consideration is cost. Aricept is usually covered by insurance, Medicare, Medicare Part D and Medicaid, but I do have a lot of patients when it comes to other medications where insurance actually either doesn't cover it or they're paying a big co-payment out of it. And I really told them, how much is it costing you? And they'll say, $20 a month, which isn't a lot, but if they're taking a lot of medications, that's 6 or 7 medications, you're looking at $140, $200 a month. And $20, I mean, I would not tell them to take this medication over, like, let's say, a high blood pressure medication or a diabetes medication or something. And with a lot of people, if money is very tight, that $20 a month, it all adds up. So cost, I say, if it's not having any side effects, you don't mind taking it, and it's not, and you can afford it, take it. But it's the first medication that I drop when cost or any side effects come into play. Yeah, yep.
I heard that if you stop Aricept, you can actually have cognitive decline. Is there truth to that?
I doubt it. I doubt it. I mean, most of the time when we stop it, we actually stop. We stop it gradually. But then, like I said, if the person's doing fine on with no side effects, I don't even ask them to stop it. So I mean, I always say they come to see me, they're already on it. It's not broken. Don't fix it. Okay. For the most part, usually, people will ask me to stop the medication because it's causing side effects, or they'll ask me, is this really doing anything? And if the patient is very, very advanced in their dementia, I'm going to say, probably not. And if you want to stop it, great. Stop it. If he seems to get worse, or if the person seems to get worse, we'll restart it again. But there's no neuroprotective effect in taking it, and there's no evidence that it's neurotoxic or bad for you if you suddenly stopped it. So this is the Namenda, right? It a lot of times we give this along with the Aricept. We give it along with the Aricept. And I always put neuroprotective here because all the drug companies want you to believe it's neuroprotective, but there's no evidence. Because if it's neuroprotective, maybe we should all be on it, right? Because I don't want to get Alzheimer's disease either. Anyone remember him?
Barry Goldwater.
Barry Goldwater.
Oh.
So, depression, I'm actually a psychiatrist also, and I actually don't do a lot of psychiatry, but actually I like it. But you're looking at 5 to 10% of the elderly population is demented, and 30 to 40% of the demented population. And then pseudo-dementia, when we are depressed, we don't remember things. We think very, very slow. We sit around like demented people. So one of the things I always do is I offer an antidepressant to almost every demented person that I see. Okay, a lot of times they don't want it. A lot of times they're clearly not demented, but I'll still offer it to them. A lot of times I'll offer it to them anyway, almost as a preventative. I mean, if you're looking at 30 to 40% with a lot of the antidepressant medications right now, you've all heard of them, Zoloft, Prozac, they're actually very, very safe. Primary care doctors prescribe them, most of them. Most of the time. I actually offer it to them, or actually at least screen them for depression. And I'm very, very quick to offer an antidepressant medication. So it's called pseudo-dementia, meaning it's not true dementia, they're just depressed. Okay, so these are the things that I will almost always use one of these. Selective serotonin reuptake inhibitors. These are the things you've heard of: Zoloft, Prozac, Paxil, Celexa. The combination, you probably heard of the Cymbalta, sometimes that's used for pain. What else is there? Effexor, Wellbutrin. Okay. These, the tricyclics, I don't really use that much in demented patients because tricyclics, they tend to be anticholinergic. Remember, demented people don't have enough of the chemical acetylcholine, and so you don't want that's something that's going to be blocking that chemical that they feel is lacking in Alzheimer's disease. These are all, this is all old stuff. I mean, this like slows down the metabolism. Okay, so, you know, you've all heard of these, Prozac, Zoloft. These are very, very safe, okay, in the elderly, for depression. I get more bang for a buck with people who are demented with these than I do with Aricept or any of those medications. Right, exactly. If you feel better, you function better. And a lot of times they, you know, if 30 to 40% of the demented population has depression, and these are clearly useful in depression, whereas Aricept in those, it's a little less, the evidence indicating that they treat dementia symptoms is much, much weaker than the evidence that these help depressive symptoms. Okay, they're safe, I said, you know, they're safe. They're very safe. You take them once a day. Sometimes you can exacerbate, because I mean, it kind of activates you in frontal temporal dementia, which is a very specific kind. It's actually not that common. You become disinhibited, you become active. I mean, the running joke is that, you know, you'll start telling dirty jokes, you know, at the holiday table with children present. You know, you become unfiltered, disinhibited. And then sometimes if you take too many of the medications, you can get psychotic, you know, serotonin. When you have too little of it, you're depressed. When you have enough of it, you're okay, you're not depressed. And when you have way, way too much of it, you become psychotic. Okay, these are some of the medications. I mean, you've heard of, you know, Cymbalta, Effexor, Wellbutrin, Zyban. Zyban also, they also noted that it helps you stop smoking. And then another symptom, delusions, right? These are all symptoms, you know, potential symptoms of depression that go beyond just the memory problems and the cognitive problems, right? Delusions, we had mentioned that before, you know, my maid is stealing from me, my cleaner is stealing from me. Hallucinations, okay? And Parkinson's disease dementia, I'm actually having visual hallucinations. They're not really sure, is it a direct symptom of the illness? Is it because there's too much of a chemical, too little of a chemical? We don't really know. Is it a result of depression, right? Depressed people, they can start hallucinating also, but depressed people, when they hallucinate, what does it tend to be? They're hearing voices, right? They're auditory, yeah, and they're what's called mood congruent, meaning that if you're depressed, the voices will say, you know, you're no good, go kill yourself. Okay, if you're depressed, the voices, and if you're manic, the voices will say, hey, you know what? You're God. You know, you're the greatest person in the world. You have all abilities. You can read people's minds. So a lot of the symptoms, like, you know, there's a lot of overlap. If 30 to 40% of the demented people are depressed, and 5 to 10% of the elderly, a lot of the symptoms could be from depression, dementia, or a combination thereof. Delirium. Delirium is when you do have an alteration in consciousness. We get called to see people like this in the hospital all the time. People who are demented are much more prone to being delirious. It's so common in the hospital because you have someone with, even with just an older person, they may not have been diagnosed with any type of dementia yet. They might be functioning fine. They might even be working on the outside. But as you get older, you have less of a reserve. When you hit the hospital and suddenly you get a urinary tract infection, pneumonia, everything gets sick. You get an altered sensation. You know, you get cloudy much more easily. We get called to see people like this all the time. Iatrogenic, older people, they're much more sensitive to drug side effects. One of the things that I see all the time in the hospital, elderly people come in, they will give you a list. They're on like 20 medications because this doctor has given some, that doctor has given some, this doctor has given some. I always encourage, you know, what do we really need? And then this gets back to what I said about, you know what, if they're on 20 medications and they're on Aricept and, you know, they don't need it. Right, and then, these can all cause cognitive problems, right? And this is actually a very, very big topic now, right? So what happens with people with Alzheimer's if they get delusional? They can get agitated, right? They can start hitting people. Alzheimer's disease people tend, pure Alzheimer's disease patients, they don't have any motor dysfunction. You've seen like people, you've heard on the news, a 75-year-old grandmother with Alzheimer's is found wandering. They've wandered 4 miles from, the bus stop or where they live. There's nothing, they're in great health from the neck down. Some of them are even very, very strong, right? So what's going to happen when a stranger comes in? They may not even recognize them. They think they're stealing from them. They get agitated. They have to be sedated. This is a really, really tricky subject because you really shouldn't be given a lot of these medications to older people. These medications are all for people with schizophrenia, bipolar people. Do you really want to give it to a 75-year-old woman? The FDA even has what's called a black box warning about all these medications, meaning that they're, quote, they're dangerous in the elderly, and they are. All right. They did I don't know. Do you remember the stats behind that? If you haven't, Jerry, it's like you're twice as likely to die from pneumonia. You're 3 times as likely to die from a heart attack. 1.5 times more likely to just drop dead when you're on these medications when you're demented.
The study was done with Haldol for sure. Right?
Yeah, it was Haldol for sure. Yeah, and then but all of them have a black box warning, and families and doctors are in a really, really difficult position, right? Because they have to take care of them. And I've had patients whose caregivers were like literally beaten up, bruised, bloodied by the people they were taking care of. And they came in, begged, can you do something? Can you do something? And then I pretty much tell them, all right, I can give them this, it's dangerous, and I'm going to document that I discussed this with you, but I empathize with you because I don't have to take care of them. Or I have people who refuse the medication, and I'm like, look, I know I'm not supposed to give these to you, or I know there's danger in giving to you, but I don't have to take care of, your mother. You do. So when you are in need, don't hesitate to do it, but I'm certainly not going to twist your arm about it. I'll get phone, I can even, think of the names off the top of my head. I get phone calls from people with elderly mothers or fathers who are just out of control, and I'll get phone calls from them. I don't know what to do. She's out in the hallway screaming. I've tried to help her, and she's already hit me. What are the neighbors going to think that when your elderly mother is yelling? That you're abusing her. Yes, you're beating her up. Who are they going to call? The police. Yeah, that's happened to me. It has happened to my patients all the time. So this is a really touchy. I put the message. You got to be really, really careful about them. All right. All these things, they can cause depression. They can cause you to have Parkinson's symptoms, cognitive slowing, fatigue, orthostatic hypotension, depression. They can cause a lot of side effects. And so it's like a deal with the devil. You're damned if you do, you're damned if you don't. You're caught between a rock and a hard place. Am I going to give them a medication that's dangerous and put them in that danger, or am I not going to sedate them, put them in danger as well as the caregiver?
Antihistamines are dangerous?
No. It has an antihistamine function, so it makes them drowsy. So it makes them drowsy because a lot of these medications they have a primary role, but then there's a lot of overlap. And the way it affects other symptoms is why all the side effects come up. Psychomotor retardation. Remember it was Muhammad Ali? Parkinson's. He has Parkinsonism. Maybe he has Parkinson's disease, but with the amount he's been hitting his head, people are very, very reluctant to diagnose him with your typical Parkinson's disease. Okay? So psychomotor retardation, it just means, you kind of sit there. All right, and then is it part of normal aging? Is it from dementia? Is it secondary to depression or psychosis? Is it Parkinsonism like Muhammad Ali? We don't know. We do know. Activity. I hope I have that slide in here because it's my favorite slide about staying active. Parkinsonism, just being slow. Okay. History of neuroleptic use. Remember when I said those medications? Haldol, that can cause slowness. So I have psychiatric patients who have been on Haldol for a long, long time, or have been on it a long, long time for the past, they have Parkinson's symptoms, but they don't have Parkinson's disease, but it almost resembles it because it involves the same chemical. They get stiff. And then a lot of the using the medication, it's almost a damned if you do, damned if you don't. If you want to loosen the person up, use an anticholinergic, but then what did I say about anticholinergics? It causes your memory to be worse because it blocks acetylcholine. Okay? You have Parkinson's disease, you want to stimulate the dopamine neurotransmitter, which is what's lacking in Parkinson's disease. But if you give, L-dopa, exactly. And if you give too much, you can get psychotic. Okay, so if you give, this is the L-dopa down here. So these two, the acetylcholinesterase inhibitors, acetylcholinesterase inhibitors, these are the medications like in Aricept, Exelon, all these are, they're very safe. Just like levodopa, carbidopa is actually very safe. I mean, anyone I think has Parkinson's disease, I just try them on the medication because there's no definitive test for it. The best definitive test is just to try it, try treating it, and if they respond to it, that's probably what it is. Oh, I'm glad I included it. This is actually done by my senior resident, when I was a junior resident, Joe Verghese, who's at Einstein right now. Leisure activities at risk of dementia in the elderly. And he basically, and this was in New England, and I love this.
It's before smartphones.
Before smartphones, yeah. Joe wasn't saying anything, or he wasn't showing anything that wasn't obviously well known already, but the reason he got it in New England was just because it was a well-designed study, okay? And so basically, he said, the conclusion, participation in leisure activities is associated with a reduction in the risk of dementia even after adjustment for baseline cognitive status and after the exclusion of subjects with possible preclinical dementia. So what they did was that they looked at people who remained active, both physically and mentally active. And what does mentally active mean? It's like they, when they retired, they played board games, they played bridge, they went to church, they went to, synagogue. They were interacting with other people. They were talking. They were doing crossword puzzles, knitting, anything using their head. Okay. They were ballroom dancing. Then they compared people who didn't, and it was all self-reported. But there was a greatly reduced risk in dementia in the people who remained active. And then the one caveat is that dementia is associated with depression in the preclinical state, especially. Thus, people who were not motivated to do all those activities were depressed and were probably in the preclinical stages of dementia, and thus the people who were able to stay active weren't going to get demented anyway. The people who were inactive earlier were slated to become demented because that was a preclinical symptom. Obviously, it doesn't prove anything, it just suggests something, but every time people ask me, is there a medication that I can take to slow the progression of it? I say, no. Well, what can I do? And then I talk about this article. And so, all right, so one thing, dementing illnesses are more than just about declining cognition. It's about psychiatric symptoms, depression, psychosis. There's a wide spectrum of symptoms. And then hopefully what I've shown you is that consider the dynamics between all the symptoms as well as the dynamics behind all the treatments, okay? So disease-specific treatments has limited efficacy. Non-specific treatment is not. So those medications that I rattle off, those are specific treatments but have really limited efficacy. The non-specific treatments, right? Walking, doing board games, staying active, going to your church, your religious institution, socializing with friends, okay? That is shown to be much more efficacious than medication. So in general, I don't have any magic bullet of it. I mean, when the symptoms come up, like I said, there's certain things that I would do. In a person that I found had Alzheimer's disease, I will tell the families, this is what you would expect as it progresses. Here are the medications that we can use that I think would be most beneficial. Someone with some other dementia, like Parkinson's disease dementia, here's what you can expect. Here's what I would do that I would not do with an Alzheimer's disease patient, because the medications that are good for Alzheimer's disease may not be good for the Parkinson's disease patient, and vice versa. And I don't think I had that final picture of my kids. I think I- No, I don't.